Hi, everyone, and thank you for joining today's virtual educational program with Cancer Support Community Los Angeles. I am Edlyn Rodarte, and I am the program coordinator at CSCLA. I'm excited to welcome you to this week's webinar titled Palliative Care, Hospice, and the Big Picture. Palliative care and hospice are medical disciplines that share similar goals, but differ in important ways. In this live webinar, Katie Poole will explore the evolution of palliative care and hospice, key concepts of each discipline, and how we tackle what it means to experience a good quality of life at any stage of cancer. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch past webinars, please visit our website at www.cancersupportla.org. Before I introduce today's speaker, please note that we cannot see or hear you. Your video and microphone are automatically disabled for this webinar. We will not be monitoring the chat room, but you may enter your questions into the Q&A feature at any time. Questions will be answered at the end of the presentation. We may not be able to get to all your questions today, but our presenter is invited to share their contact information at the end of the presentation. Without further ado, I'd like to welcome today's speaker. Katie Poole has practiced as a clinical oncology and palliative care social worker for the better part of the last decade. Since earning her master's degree in social welfare from UCLA, Katie has specialized in working with adults who live with cancer, neurodegenerative conditions, and other serious illnesses. She holds certification in Oncology Social Work and Advanced Hospice and Palliative Social Work, and has contributed to projects accepted by the American Academy of Hospice and Palliative Medicine, the Center to Advance Palliative Care, and the End-of-Life Nursing Consortium. She is now honored and delighted to be part of the team at Mann UCLA Center for Integrative Oncology. Welcome, Katie. Thank you so much for joining us today.
Thank you, Edlyn, so much for having me. Thank you, everybody, for joining today. My name is Katie Poole. I'm a licensed clinical social worker specializing in oncology care and palliative care. I am so grateful to be here. These topics are close to my heart, and I'm always grateful for an opportunity to share this information in order to help our patients and their communities be more informed and empowered about their options for their care. I would also like to thank you in advance for your patience. I'm a little under the weather today, and so that may come through in my voice. I may also have to silence to cough, so thank you so much. A little bit of history about me and sort of how I gravitated toward these specialties in oncology and palliative care. My primary work settings have been in the outpatient sphere, which means that I spend most of my time working with patients and families who are not in the hospital. So if you have an appointment and you go to a clinic to see a physician, that is the outpatient setting. And one of the great things about outpatient work is that I have the privilege of working with patients and their loved ones over time, not just during an admission. So in my past work experience, that meant I had the privilege of working with these families over time. So not just for a few days, not for maybe a week during the hospitalization. It meant that so long as these patients were being followed or being seen by our physicians in our clinic, that meant I had a working relationship with them. I often remained in touch with them once they transitioned to hospice as well. And being able to have these long-term relationships with these families meant that our patients had time. They had time to ask questions, to better understand their medical care, to brainstorm treatment options with their oncology and palliative care teams, to discuss their personal priorities, which sometimes get laid by the wayside in the context of pursuing treatment. And we also had time for them to tell the team how their own goals and values would influence the decisions that they made pertaining to their medical care. So one thing I want to reinforce is that if you or a loved one have cancer, you are the expert in what this cancer means to you. Palliative care as a broad discipline is holistic. And so we're looking at not just at a diagnosis, but at the whole person. And so the title of today's presentation is, the big picture. And that's you, your wishes, your goals, your hopes. That is the big picture. And my hope today is to share this information that will help you feel informed and empowered as you navigate your care. So first things first, let's go ahead and start sharing. Let's see. Okay, I think that is up now. So palliate, right? So to palliate means to make a disease less severe without removing that cause. Palliative medicine, in this initial definition, first emerged within the context of hospice. So over time, though, the general medical field saw how hospice improved the quality of life for patients and families and thought, hey, maybe we should consider introducing these effective and supportive strategies sooner than the end of a person's life. And so that's where the more broad discipline of palliative medicine and so kind of came into play. So this is when patients were undergoing disease-targeted treatments for a serious illness. In cancer, that means that you can access palliative care while you're doing surgery, while you're doing radiation, while you're doing chemotherapy, because helping manage the symptoms that arise, either as a result of the treatment itself or the cancer, help and make it possible for you to live a higher quality of life while you're pursuing treatment. So we saw these two disciplines, palliative care and hospice, emerge as related but distinct disciplines. So they have the same premise: to enhance quality of life through symptoms management and the active incorporation of a person's own goals. And they can be introduced at different times in a person's care. Ooh, that's helpful. All right, so here's where we've got a little bit of an overview. We'll do a little history, kind of talking about the last 50 years or so. We'll do some hospice and palliative care 101, going over what is similar and different between the two. Talk about some good concepts like goals of care and other important conversations, which leads into advanced care planning. That's sort of the practicalities of goals of care discussions. And then we'll wrap up with a summary and then open for questions. So 1967, and we're just going to skate right through this. Dame Cicely Saunders is the mother of hospice. She had degrees in nursing and social work and medicine. And we will talk more about her concepts in a bit, but the very first hospice opened in London in 1967. A couple years later, Elizabeth Kubler-Ross published a book called On Death and Dying. And this was revolutionary because it raised awareness about the kind of care that people receive at the end of life. And her focus on the topic started to normalize a discussion around these topics, which had been much more private, much more discussed behind closed doors. It became more of a public sphere conversation. 1974, we saw our first hospice here in the US. And also in 1974, Dr. Mount was a surgical oncologist, and he started coining this term palliative care to differentiate from the care that we provide prior to hospice. And then we've got the Cleveland Clinic opened their first hospital-based palliative care program in the US in 1987. So what we had, again, was a trajectory from hospice into, oh, actually, we can introduce this sooner. Let's introduce it in hospitals. And over time, they expanded it further into outpatient settings. And now they've got more pilots around home-based palliative care that is not hospice, but a palliative care provider can come to you at home. So it's been very interesting to see how that changes over time. 1990, the World Health Organization recognized palliative care as a distinct specialty. So we're looking at some increased legitimization within the medical field here. 97 was a big year because this report published by the Institute of Medicine noted discrepancies between what American public said they wanted their ends of life to look like, and then what actually ended up happening in practice. We found that the medical system by default was to treat into oblivion, even though if given more opportunities to discuss and say like, hey, what would you like to be doing? Maybe seeing the last of their days in the hospital was not actually aligned with what people were interested in when asked specifically about that. And so recognizing the breakdown between what people said they wanted and what happened without the conversations about what they wanted. 2004, palliative care is formally recognized as serving not only dying patients, but those with life-limiting illnesses. Life-limiting is an important term. So we define that as a condition that will shorten a person's life, though they may continue to live an active life for many years to come. So again, that is not a 6-month prognosis. That could be years, and it could be years with treatment. It could be years without disease-directed treatment, such as chemotherapy. But just sort of recognizing this, a person has a diagnosis, that could, that is likely to result in their death, but it is not going to happen soon. So palliative care legitimized as something that could be made available to people much sooner. Further legitimization in 2006, as this was recognized as its own specialty. And then in 2010, a study showed that people with lung cancer who received early palliative care, in addition to standard cancer care, experienced less depression, an increase in quality of life, and they survived 2.7 months longer than those receiving cancer-directed treatment alone. So that combination, right, of the cancer-directed treatment, such as chemo, surgery, radiation, as well as the symptom management affiliated with palliative care, saw that increased quality of life. And this is the real question, right? What can palliative care do for me, for you, for all of us? And so we have these palliative care and hospice providers who specialize in symptom management and optimizing quality of life. That point applies to both palliative care and hospice. The symptoms that are described below, they can be physical, emotional, or both. Those are things that palliative care and hospice teams are going to be looking to alleviate. Both hospice and those broader palliative teams rely on interdisciplinary teams. So that means that you've got the physicians, you've got nurses, you've got social workers, spiritual support staff, pharmacists, and so on. You are getting input from a whole collaborative group of people who are interested in alleviating that suffering. A phrase you may hear, you may have heard, and we'll certainly hear again in this presentation, is that all hospice is palliative, but not all palliative care is hospice. And so you can see here in the figure on the left, that's what we're talking about. Palliative care is a big topic. We can have it in hospitals. We can have it in an outpatient clinic. We can have it in hospice at home. And we are still developing new ways as a field of offering it in new and interesting settings, right? I mentioned before that they're now starting to explore some pilots around home-based palliative care that isn't hospice. Okay. As you pursue curative cancer, I'm talking now about the figure on the right. Okay, so as you pursue curative cancer, that surgery, chemo, or radiation, you can also obtain palliative care for symptom management and quality of life needs. So over time, though, as different cancer treatments are exhausted, then the white section starts to taper. So let's say right there at the beginning, right? Focus of care, you have a diagnosis of a serious illness. And so we're really focused on curative care right out the gate. And maybe we have a little bit of palliative care to help with the symptom management. And so you can see that blue section below. As we exhaust various options for treatment, maybe what we are seeing is an increase in palliative care within the ratio of the kinds of care that are being offered. We focus even more on maintaining and improving health throughout palliative care over time. And when someone is estimated to have a 6-month prognosis, maybe then we start to consider hospice care. You can see that yellow box there. Hospice follows for end-of-life specific palliative care, as well as for the bereavement support of surviving loved ones. And so you can see that's that triangle extending past the time when someone has passed away. Usually that bereavement support lasts 13 months, which means that the hospice team sees the family through that full first year. And I want to bring that to your attention because that means that hospice really does, and I would say palliative care broadly, but hospice care in particular, really thinks of not only the individual as the patient, but the whole family or the whole system that is involved in supporting this person. And so they are going to have that wraparound support while the person is alive and requiring that medical care, and they'll continue to care for their surviving loved ones afterward. I appreciate this figure on the right. I mean, it's from the Department of Healthcare Services, but it does a really nice job of just sort of clarifying how they work in relation to each other. You can see this relationship of cancer-directed treatment, and we're heavy on that in the beginning. Over time, maybe we emphasize a little more standard palliative care, and eventually maybe we transition to hospice care. And this is all going to look very different and unique for every person. So we're going to talk about some important terms next. First, quality of life, assessment of a person's well-being or lack thereof, right? Because when we say quality of life, we are allowing for the possibility that maybe it is not good. And so this includes emotional, social, and physical aspects of the person's life and how these are affected by a medical condition. Some examples could be that somebody uses to define their quality of life is, are they able to spend time with their family, or are they spending all of their time in the hospital? Are they able to communicate meaningfully with their friends? Sometimes people decline a ventilator because that, or over not over medication, but sort of some people have reservations around pain medications, and often you can work with a palliative care team to make sure that you are not so sedated by a pain medication that you can have those meaningful interactions with your friends and loved ones. Other people are going to say, man, my priority is spending time on my porch at home with my cat on my lap. And these are the things that don't necessarily get talked about as frequently when you're in the room with your physician. But with a palliative care team, these are exactly the sorts of things they want to know about. They are interested in exploring your quality of life for you, for your loved ones, and are going to be invested in improving that quality of life for people whose needs are most complex. And this is the concept of quality of life is rooted in the idea of total pain. And that's the idea that social, emotional, and spiritual factors all contribute to the ease or difficulty with which we experience good quality of life. It's not just physical. Pain is more than physical. The concept of total pain or total suffering actually comes from Dame Cecily Saunders. She's hospice mama, right? Who believes physical symptoms are only part of a person's experience. So we have these four components now. We have the physical, we have the psychological, we have the spiritual, we have the social. And they all work together to increase a person's stress and physical pain. Here's a quick little breakdown of them side by side. So to summarize, palliative care can help people with serious illness to live better with their disease. It is specialized medical care that focuses on relieving the stress and suffering of serious illness with the goal of improving quality of life of the person and their loved ones. It is appropriate at any age, it is appropriate at any stage in a serious illness, and it can be provided alongside that curative treatment. Hospice, and you'll notice I've got a couple asterisks in the section under hospice, and I'll tell you why when we get there. So first is the prognosis of 6 months or less. I've noted an asterisk because nobody's got a crystal ball, and because a more accurate way to describe this qualification would be to say, would my doctor maybe be surprised if something happened in the next 6 months to result in my death? And if that isn't out of the realm of possibility, then maybe the wraparound support of a hospice care team is something to consider. Another thing is, if I enroll in hospice and then 6 months come and go, am I then kicked out of hospice? Well, most insurance plans have actually structured the hospice benefit as something that can be recertified and extended so long as another 6 month prognosis is within the realm of possibility. And so I have had some patients be on hospice for multiple years practically. But that's so hence the asterisk of must have prognosis of 6 months or less. That is something to explore with your doctor. And then we talk about foregoing life prolonging treatment. Right. And that is for the terminal diagnosis. So if somebody has cancer, and they want to enroll with hospice with cancer as the qualifying terminal diagnosis, then they would not be able to pursue chemotherapy or sort of disease targeted treatments like that. Now, if they need to go see their podiatrist, that is not related to that terminal diagnosis. If they need to see other specialists for other conditions that are unrelated to the terminal diagnosis, then you are still getting your medical care. And so I want to zoom over really quickly to the palliative care section and think about a related but broader question, which is, okay, so let's say I've got palliative care, let's say I've got hospice, right? What about the rest of my doctors? Palliative care on the left side there is typically going to collaborate with your other doctors to provide that specialized layer of support. Okay, so it is really common for the palliative care team to talk to the oncology team, to talk to the neurology team, the whole crew. Everybody's in contact with each other. When somebody enrolls in hospice, the hospice team usually takes over the care for a person's medical needs, and this makes sense because if you are getting people visiting you at home to care for you at home, those are maybe the people you want managing your care. They're going to be boots on the ground, really attuned to your medical needs, the needs of your family. And so they take ownership of a lot of your care needs. And so it is, and frankly, if you are enrolling with hospice because it is too much to be going to the hospital, if it is too much to be coming to your medical appointments, there is a benefit to getting that care at home and no longer needing to keep those appointments with those other specialists on an outpatient or an inpatient basis outside of the house. So I want to come back to that idea of forgoing life-prolonging treatment. Stopping treatment aimed at curing cancer does not mean discontinuing all treatment. If somebody decides to enroll with hospice because the cancer is no longer responding to chemo, they can still get medicine to manage high blood pressure and other non-cancer conditions. These are some of the most common hospice myths I've encountered in my work with patients and their families. So first, to even qualify for hospice, you have to be bedridden, housebound, unable to communicate with others, or in the last few days of your life. What I have heard time and again is like, oh, I don't want hospice. Hospice is where you go to die. And this is a challenging thing to hear as a provider because the goals around hospice, around palliative care broadly, but particularly around hospice, around deciding to use hospice means that a person who is dying will ideally spend more quality time with the people they love and on the other activities that are meaningful to them. Just because somebody's approaching the end of life does not mean we're already at the 11th hour necessarily. And so when we wait until the 11th hour to transition to hospice, right, which is the sort of decision that can really reinforce this idea that hospice is where you go to die, then we're actually missing out on the benefits of hospice. And I'll explain why. Transitioning to hospice care involves an initial flurry of equipment being delivered, introductions to the hospice team, and other really important supportive measures. But that first week or so is wild. It's really busy as they are starting to take over all of the care and making sure that they know exactly what needs to happen, when, and how best to support you. Now, if someone waits until the last day or two of their life to enroll with hospice, then what they and their family experience is that initial upheaval rather than the ongoing stable consultation of the hospice team after that first few days. If you wait until the 11th hour, you don't get to take advantage of hospice's longer term benefits to quality of life. You don't have to be bedridden to be on hospice. You don't have to be housebound. I know patients who have enrolled with hospice because doing so allowed them to then travel throughout the country and visit their loved ones. Once a person enrolls with hospice, there's no going back. That's myth number 2. That is not so. You can disenroll from hospice at any time. I would not necessarily recommend boomeranging back and forth on and off hospice necessarily, only because that can really disrupt continuity of care as the providers swap out. But you can go to the emergency room or disenroll entirely if you wish. One of the benefits of hospice with that wraparound care is that if you have acute symptoms in the middle of the night, you can call the hotline 24/7 and consult with the on-call team and say, hey, here's what's going on. Can you guys and they will try to support you over the phone, get it resolved over the phone, provide recommendations around medications to hopefully get that under control. And if that isn't sufficient, they'll send an on-call nurse out. Now, for most people, that's exactly what they want. They are not interested in going to the hospital. Some people say, actually, forget it, I'm going to the hospital. And you are allowed to disenroll entirely from hospice at any time. You are allowed to choose hospices and then switch to a different one. Hospice is meant to be a supportive option. It is not meant to be a corner into which you are backed. And last, the myth that hospice means giving up hope. And I want to allow for the fact that this is part of a broader conversation that we will pivot to in a minute. And what I'd like to propose is that because hospice involves coping with death, part of that means acknowledging that some diseases in their advanced stages cannot be cured. And so that's tying into a bigger idea that everybody has goals for themselves, for their care, and those goals can actually also change over time. And even if an outcome is not what we initially hoped for, it is still possible for us to find meaning and comfort and a sense of hope despite the changing circumstances. So that common goal of palliative care and hospice is to improve the quality of life for an individual and for their loved ones. If we come away with nothing else today, I hope that is the piece. This is a really common question I've gotten over the years. How do I know when it's the right time for hospice? So in palliative care, we strive to help our patients identify their own priorities for their medical care. Just because we can treat a disease into oblivion doesn't always mean that it makes sense to. Let's take a couple of hypothetical people. Let's say person number one really derives a sense of peace from believing that they did all they could. This is important to them, right? Even if the treatment leaves them bedridden or dependent on a ventilator, right? Now, for somebody else, person number two, maybe they feel it is more important to participate with their environment in a very specific and meaningful way, however they define that specific and meaningful way, whatever that means to them. And so they may opt to stop treatment altogether if they believe that treatment will prevent them from that meaningful participation. It really comes down to whether the care plan aligns with your own values and wishes. Does it sound more like person one's goals kind of align with yours? Does it sound like person two's goals align with yours? There is no right or wrong answer. It's just about what's right for you. So we start by asking these questions, and these questions really just kind of come down to the eligibility criteria for hospice, okay? So have you and your oncologist discussed prognosis? That comes back to that question of like 6 month-ish, right? And again, there's a question mark there. And is that information you would like to have? Not everybody wants that info. Maybe a relative, maybe your partner wants it, but you don't. You know, there is room for those kinds of conversations too. Do you wish to pursue cancer-directed treatment like surgery, chemo, radiation? Now, if there's some wiggle room here. Sometimes hospice agencies will allow for what we call palliative radiations. We're not aiming at curing cancer. We are maybe radiating a section of the body to help alleviate pain. Okay, so that is considered palliative, right? So there's a little wiggle room there, but by and large, if we are looking toward cure, and often that's something that is attempted through surgery, chemo, or radiation, then we need to ask whether hospice is aligned with what we're looking for ourselves. And finally, if you experience uncontrolled pain or other severe symptoms, would you prefer to go to the hospital or have a hospice team respond to you at home? Once again, no right or wrong answer. But for the person who's like, forget it, I'm going to the hospital every time, then the hospice is maybe not the best use of resources for them. Maybe they should go ahead and rely on the hospital. But for somebody who says, man, I am sick and tired of the hospital. If I never see the hospital again, it's too soon. Then maybe hospice is going to be more appropriate. Once again, there is no right time. It is just going to depend on a person's own individual goals of care. And that leads us into this next section here, talking about goals of care. And you may have come across this even before today's presentation. A goals of care conversation is a discussion that happens between a person, their medical team, and any involved loved ones, right? To help clarify what the person values and what they hope to see happen with their medical care. It helps an individual living with a serious illness clarify what they value most and what they hope to see happen with their medical care. And this is something actually that palliative care teams, this is what they're trained in. This is, if there's a superpower, that's the one. This is the one for palliative care teams. And that's really great because understanding our patients' care goals is essential to providing high quality care. When we find that when goals of care are incorporated into the discussions with the healthcare team, we find improved quality of life, and you probably expected that one, better patient and family satisfaction, more goal consistent care. Is the medical care that you're getting what you actually want? Less unwanted and non-beneficial care. We're not doing something just because it seems like the next thing to do, right? And reduced healthcare costs. One thing I want to emphasize is when we talk about goals of care conversations, these are not one and done type conversations. These are going to happen over time as the nature of a disease changes, as our prognosis or trajectory shifts, as our own opinions, as we learn more about the medical system or whatever options are available to us, our opinions may change too. And so goals of care conversations are something we revisit time and again. And that's important. So quite often, especially if somebody's just been diagnosed with cancer or have just been too sick to really sit back and think through their options, it's common for people to not necessarily have considered what kind of care they want. And you may not always realize that you have choices. One of my hopes, and the hope of many of my colleagues in oncology and palliative care, is to help our patients make informed and empowered decisions about their care, to help you make informed and empowered decisions about your care. And so 3 broad topics, right? Or types of care, and these goals of care discussions can help facilitate that shared decision making and promote advanced care planning that can help you decide, hey, where am I in this? Curative care, maintaining and improving health, and comfort care. And I think, we aim for cure whenever possible, and there are times when it isn't, but palliative care has always been a prioritized comfort by incorporating quality of life, symptom management, and these goals of care conversations. So curative care, we're focusing on quantity of life. We're thinking about quality too, but we're really looking at lengthening life. Maintaining and improving health. So we're still focusing on those treatments, right? But we're also starting to incorporate more of a focus on the quality of life piece. And this is maybe where folks start bringing in the palliative care team. And so curative care can happen concurrently with maintaining and improving health. And over time, it is possible that we're going to transition to comfort care. So at this point, it is possible that the disease has progressed to an irreversible state. We do not have the option of cure, in which case we are really putting our efforts into quality, because that is what we control at this point. One of the things we say is cure sometimes, cure where possible, right? But comfort always. That is always going to be a priority from our perspective. And here are some questions you can ask yourself around your own goals of care. Each of us can consider this. We can think about it on our own time, just sort of internally. We can discuss it with our loved ones. It's always good for them to know what's important to us. And we can explore it with our medical team. And what's great, I'm a big fan of when all 3 are happening, right? So what do you understand about your overall condition and medical illness? Some people want to know as many details as possible, others don't. Both are okay. Know what feels right for you. Have your doctors told you about what to expect in the future? How much information do you like to receive from your medical team? That comes back to that question of how much, how many details do we need? Do we really want? And again, some people really want all of them, and other people want the functional step A, step B, step C information. What do you hope for with treatment? What are your worries or concerns? How are you coping? How are your loved ones coping? How is your quality of life, and what makes it so? And it is good when we can get specific here, right? Not a right or wrong answer. It can be a great quality of life. It can be a really crummy quality of life. It can be somewhere in the middle. Okay, but what helps make it any of those things? What parts of your life are influenced by your medical care? Where can we kind of intervene and make adjustments so that we can improve and enhance and optimize what we can? Do you have any advanced care planning documents? We'll talk about that in a little bit. I want to come back really quickly to the loved ones coping though, before I forget. Your palliative care and hospice teams are all going to be interested in not only how you are coping, but how your loved ones are coping. If any of you are struggling, let your teams know. And then finally, of these questions, are there any that you'd like to discuss with your medical team? That's that little reminder. Check in with your team. Let us know what's going on, what's on your mind. So as you talk with different doctors, you are getting a ton of information and recommendations, right? It's like somebody dumped a jigsaw puzzle. Hey, check it out with that image. It's like somebody dumped a jigsaw puzzle on the ground and said, have at it. But then they also took away the box with a picture on it. So like now you're just going to sort of blindly start putting these pieces together. But this is where palliative care kind of comes in. We can work with you to help identify your priorities and your values and goals that are important to you. And with that big picture in mind, right? We can support you in evaluating treatment options to see if those options are aligned with your goals. So if we have oncologists who focus on oncology, and we have neurologists who focus on dementia, Parkinson's, other neurological diseases, you have oncologists who specialize in medical, surgical, and radiation oncology, right? So the palliative care providers are going to be experts in their own discipline. We are going to be supporting you in these conversations to introspect and reflect and talk with your loved ones so that everyone's on the same page about what the big picture is. You are the big picture. You are putting together your own big picture to reference as you get new options, new ideas about what treatment avenues exist. And you can decide what next steps in your care plan make sense and reflect your wishes. This is a little cliche, but I like it. And so putting together a puzzle is easier when you can look at the picture on the box. And I've heard people ask before, shouldn't my oncology team and other specialists be invested in controlling my symptoms, knowing the goals of care, and enhancing my quality of life anyway? And yes, of course, and they do insofar as they are able. And some of them are really good at it. What is nice about palliative care and hospice teams is that those folks are board certified in this specialty. They have the time, they have the expertise to attend closely to these conversations with you and to guide you through the process. So we've covered how palliative care is a broad discipline, including hospice, optimizes quality of life through symptom management and goals of care conversations. These goals of care conversations lead naturally into advanced care planning, which helps adults of any age or stage of health understand and share their personal values, life goals, and preferences regarding future medical care. I want to acknowledge the fact that sometimes we're a little intimidated by the idea of advanced care planning. It can feel scary, it can feel hard, it can feel a little daunting. Like, what do you mean this is the potential outcome that I can't even fathom coming to pass, right? I've encountered folks who worry that discussing this is akin to speaking it into existence, right? This idea that if I think too much about the idea of going on a ventilator, then something bad will happen and I will be on a ventilator, right? But I just want to offer this normalization that it's very normal to talk with your doctor about a plan for treating a symptom, for treating a disease. And that's part of how it works, right? And so you can think of advanced care planning as an extension of those kinds of treatment planning discussions. This is just a bigger picture approach. California has two important advanced care planning documents. We've got the Advance Directive and we have the Physician's Orders for Life-Sustaining Treatment, or the POLST. And you can always complete these forms on your own. You don't need a palliative care or a hospice team to do it. But if a person has a serious illness or really complicated care needs, then they may be interested in talking with a palliative team just to sort of keep all of the different pieces organized. When it comes to feeling reluctant when it comes to being reluctant about the idea of approaching these conversations, one patient once said to me, "It is always too early until it's too late." And that was their galvanizing thought. That's what sent them into okay, I really need to work on these forms mode. I mentioned the two forms. I'm not going to go line by line through them today. I just want to make sure you know their names and their basic function and where you can find them. I'll have links to the forms in the resources page at the end as well. And so this just sort of reinforces what we've talked about already, right? Goals of care and advanced care planning, not a one-time conversation. This image is from the Coalition for Compassionate Care of California. It's a great organization, lots of excellent resources. And this is kind of how we approach it, right? You think about what is important for you. You select a healthcare agent. A healthcare agent should be somebody who is over the age of 18, somebody you trust to advocate on your behalf if you are unable to communicate with your healthcare teams. And they should have a good understanding of your wishes for your care. It is really difficult to be named a healthcare agent, but then have no clue what your person wanted, actually. So make sure that that discussion is happening there, where you're telling your wishes to the healthcare agent and your other loved ones. It is great when we're all on the same page. I would say that the conversations are even more important than the documents. The documents are a really handy tool, especially for those of us in the medical setting. If for some reason we're having a hard time reaching a human that loves you and knows your wishes, then it is nice to be able to reference a tool and that you have signed and said, here's what I want. And that is a really important function for these advanced care planning documents. So the Advance Directive, the POLST, making sure copies periodically review these documents. Do so when there's a change in your health, when there's a change in your goals or values, or in your relationships. A patient I worked with years ago was legally married to her spouse, but they had been estranged for over a decade, and he knew nothing of her cancer. So, but he was still her legal next of kin. We really prioritized completing an advance directive to make sure that the patient's sister would be the physician of healthcare agent. The advance directive, I think, is the most basic one, right? This allows you to designate a healthcare agent, dictate basic care priorities. And you can use the resources listed here, and they'll be listed again, to sort of start working on that on your own, or with your team and with your loved ones, because they are also part of the team. Physician's orders for life-sustaining treatment. This is the bright pink form called a POLST. So the POLST does not replace an advance directive. It works together with the directive to capture more specific details about your wishes. It needs to be completed by your doctor or another trained medical provider. It is not going to expire, so you have to complete a new one if anything changes. One of the things that it talks about is like CPR, DNR, and allow natural death, or you may see AND, standing for, which is short for the allow natural death. And the reason that this is important is that resuscitative measures may not be for everyone. Depending on a person's condition, heroic measures like CPR may actually put them in a really fragile state after CPR is conducted. So if a patient ever tells me they are certain they would want DNR status in order to be allowed that natural death, then I would strongly encourage them to complete the POLST, because this is the document that will protect them in that manner. My goodness, already. Time flies when you're having fun, y'all. These are the things that I think are most key to take away today. So first and foremost, palliative care works to enhance quality of life through symptom management, goals of care discussions, and advanced care planning. Anyone with a life-limiting illness can access this support. All hospice care is palliative, but not all palliative care is hospice care. Hospice care is specialized. If palliative care is a broader circle, then hospice care is going to be that specialized care focused on end-of-life palliative support. You are best served when your loved ones and healthcare team clearly understand what you want. And cure sometimes, comfort always. You are always entitled to comfort. My deepest wish for all of you is to feel informed and empowered as you make decisions about your medical care. Your values, priorities, and goals should be the foundation for any steps taken during your care. And we always hope and strive for a cure, but if a time comes when cure is not a possibility, again, you are still entitled to care that is fundamentally centered on your individual needs. I'm very grateful to all of you for your interest in these topics today and for joining me this afternoon. Thank you so much. If anybody has any questions, I welcome them. I'm going to go ahead and share. Here's a brief overview of the sources, and I can leave the resources page up while we take questions.
Thank you so much, Katie. The presentation was great. The information you provided is definitely something that should be shared, especially because I don't think a lot of people, like you mentioned, know the difference between palliative care and hospice care. So thank you so much. We do have a few questions that came through. The first one is, do you recommend a palliative care consultation at or shortly after diagnosis?
Great question. I think it is something, so it's this, I don't mean this is a non-answer. It is going to depend. I think it is reasonable for you to explore the possibility of palliative care at any time. I would say situations that come up that really warrant palliative care support are when symptoms are either they're already a problem or you anticipate them becoming a problem due to the nature of an illness. And so that can be a topic that you explore with your oncologist.
Thank you. We do have another question. Participant started off by saying, thank you for all the great info. She did mention that her husband is at Kaiser, and how do they find a palliative care person / team there?
Mm-hmm.
Or what are they called? Are they found according to the illness you have? And can we call the palliative care team anytime her husband has a symptom that we don't know how to react to?
Great questions. I am going to answer them, and Edlin, you'll let me know if I'm missing anything.
Yeah.
Great question about what are they called? I have encountered palliative care teams call themselves palliative care. Other times they call themselves symptom management service, or supportive and palliative care, or like supportive care, maybe. I hate to say it, because I think we're making improvements in this area within the general medical field, but it is possible that a medical provider that you speak with, when you ask, hi, how do I connect with palliative care, is going to say, what? You don't need hospice. And so there is still education to be done within our field to make sure that everybody's on the same page, that palliative care does not necessarily mean just hospice. And unfortunately, that means that although we're making progress, sometimes the onus is on our patients to ask for what you are entitled to and to educate your own providers about the language or the referral that you're requesting. And so any of those phrases, I'm not sure offhand what Kaiser, I would imagine that Kaiser has outpatient palliative care team. Again, you can have, it has become very common to have it on an outpatient basis, so a palliative care clinic. Many major hospitals have an inpatient consultation unit. And so you would speak to the attending in a hospital to ask for a consultation with the inpatient palliative care team. If you are getting outpatient oncology care and you would like to connect with palliative care management support, I think that's maybe a good way to
Uh-oh, Katie, did we lose you? Oh, there you are. You're back.
Sorry.
It's okay. It's okay. So we did catch the last part where you said that they can ask the attending how they can. Yeah.
Okay. I'm so sorry, you guys. I don't know what happened with the internet there. Let me say, okay, summarizing briefly. Great question. Phrases that get sometimes substituted or euphemisms for palliative care could be symptom management services or supportive care or supportive and palliative care, right? And so these are sort of the terms. So if you were to approach your oncologist and say, hi, I'd like a Did that disconnect again, Evelyn?
A little bit, yeah. But it's okay. Is there a contact maybe info that you'd like to share?
Sure.
You could send it to me, Katie, and then if anybody has, I think the connection just might be cutting out. And that's quite all right. Thank you so much. Can you hear me? No, you're good. You're good. Everyone, thank you so much. If you would like if you have a specific question, I'm so sorry. You can send us an email at info@cancersupportla.org, and we can get that over to Katie, and then she can answer that question for you. Thank you, Katie, again so much for your presentation, for everyone joining us today. Again, this is honestly really, really a great resource for us to have as well. And thank you everyone for joining. Thanks.
Thank you, everybody. Appreciate your time.
Bye.